Usually, when you buy a premium subscription, there's an expectation of basic access,
Right, you pay the fee, you get the service.
streaming, gym membership, whatever, straightforward.
Then you step into American healthcare, and that simple transaction disappears.
You pay thousands in premiums and get a rule book, a doctor directory that's outdated by Tuesday, and a billing department speaking its own dialect.
It feels less like a service and more like a maze.
A maze that's being redesigned while you're in it.
And that's the bigger point today. The old idea of health insurance as a comprehensive safety net is splintering.
We've been looking at the July 2026 SWFT Healthcare Market Intelligence Brief, along with KFF, STAT, the Associated Press, and Healthcare Dive.
The question is simple. Why does seeing your doctor feel harder now? And what does that mean for your wallet?
Because healthcare isn't just getting more expensive, it's becoming conditional.
Every major player seems to be looking at the economics and saying, we're not eating the bad math anymore.
Insurers, hospitals, employers, same instinct.
And when everybody tries to dodge the cost at once, somebody ends up holding a very expensive bill.
Start with the Affordable Care Act marketplaces. The numbers are rough. The Associated Press and KFF report enrollment dropping from about 22.1 million to 19.2 million.
So by February 2026, there were nearly 3 million fewer people with effectuated coverage than a year earlier.
And it wasn't even. Ohio and Oklahoma were down more than 32%. Florida alone lost about 443,000 enrollees.
New Mexico was the only state that grew, and that was because it added replacement state subsidies.
At the same time, insurers are asking for a median 14% premium hike for 2027.
On top of roughly a 20% jump already seen in 2026.
That's how an affordability death spiral starts to look real.
The dinner analogy works here. Big group, split the check evenly. A few people order Wagyu and wine, most people have salad and water.
Then the salad people look at the bill and say, no thanks, I'm not doing this again.
Exactly. The healthier, price-sensitive people leave, the average cost for the people left goes up, so the next round leaves too.
And that same dynamic is leaking into the commercial market. STAT reports small businesses are pulling back from traditional fully insured group plans.
Because premiums are outrunning wage growth and business revenue. So employers shift risk. They move to level funding, raise deductibles, or use ICRAs.
Individual coverage health reimbursement arrangements.
Which basically means, here's a fixed stipend, you go buy coverage yourself.
Now, somebody hears 14% and says, isn't that just inflation? Groceries are up, housing is up.
Partly, but the carriers are citing something more specific, worsening morbidity.
Actuarial language for saying the remaining pool is sicker and needs more care.
Add higher utilization and rising drug costs, and the medical trend is running hot.
And just looking at the policy mechanics, not taking sides, reducing federal subsidies for ACA plans does save money in the short term.
But the trade-off is millions dropping coverage because they can't afford it.
And those people don't stop getting sick.
They show up uninsured, often in the emergency room. Hospitals eat more uncompensated care than push those losses onto commercial payers, meaning employers and people paying premiums.
So the bill comes due anyway.
The carriers are feeling it too. Healthcare Dive highlighted Aetna. In 2023, it had about $3.9 billion in operating income.
Then in 2024, it swung to about a $984 million operating loss.
That's nearly a $4.9 billion reversal in 1 year.
Which sounds absurd until you look at the squeeze. Delayed care from the pandemic finally hit the books. Joint replacements, elective surgeries, all of it.
At the same time, the government tightened risk adjustment rules. Medicare Advantage plans had been coding patients as sick as legally possible on paper to get higher payments.
Then the crackdown shrank revenue right when medical costs were surging.
So when a carrier says we've regained control of medical cost performance, translate that.
It usually doesn't mean care became cheaper.
It usually means narrower networks, higher out-of-pocket costs, tougher utilization management, or exiting markets that don't work financially.
Like Centene leaving the Arkansas Medicaid expansion program, our home, for 2027.
Right. Once the contract expires, if the economics are upside down, they can just refuse to renew.
That tells you the strategy has shifted from pure membership growth to underwriting profitability.
And once insurers get more selective, the fight lands at the hospital doors.
KFF's Medicare Advantage numbers are revealing. In 2024, Medicare Advantage plans processed 52.8 million prior authorization requests just for post-acute care.
Meaning skilled nursing, inpatient rehab, that sort of thing after a hospital stay.
And 4.1 million were denied. That's a 7.7% denial rate.
Only 11.5% of denied requests were appealed by the patient or physician.
And on paper, somebody could spin that as proof the denials were medically appropriate.
But low appeal rates don't prove that. They show how exhausting and opaque the appeals process is. These are often older patients after a stroke, a fall, major surgery. They're not in shape for a bureaucratic cage match.
And discharge planners aren't sitting around with 5 free hours to argue on the phone.
So it becomes a war of attrition. Denials may save money today, but they can also mean delayed recovery, longer hospital stays, and more readmissions later.
Hospitals are pushing back. Becker's Hospital Review tracked 23 major health systems dropping or planning to drop selected Medicare Advantage contracts in 2026.
That's a big warning for patients. People see a broad provider directory during open enrollment and think, good, my hospital is in network.
But that network can become a mirage if a major system ends the contract because it's tired of denials, administrative burden, and slow reimbursement.
Hospitals used to fear losing volume. Now, some are willing to lose volume to reduce friction.
Meanwhile, underneath all this, there's a quieter financial reshuffling. The script flags 3 examples. Ascension buying Williamson Health in Tennessee for nearly $1 billion. Private equity using joint ventures with nonprofit systems, and copay assistance accumulators and maximizers.
Start with the copay piece because it's infuriating. A drug company provides copay assistance for an expensive specialty drug. The intermediary takes that money but doesn't count it toward the patient's deductible.
So the plan benefits, the patient doesn't get credit.
Right. When the assistance runs out, the patient is still exposed because the deductible hasn't budged.
Then there's the private equity joint venture model. Instead of buying a hospital outright and triggering obvious scrutiny, a firm can create a management services organization, an MSO, and partner with a nonprofit.
The nonprofit keeps the license and the charitable face. The MSO takes over billing, staffing, IT, revenue cycle, the whole back end, and charges hefty administrative fees.
So cash gets siphoned without an obvious outright takeover.
That's the mechanism described here.
Now Ascension buying Williamson Health. In the script, that's framed as a regional market power play tied to site-neutral payment reform.
Again, just mechanics, not politics. Historically, Medicare might pay one rate for a service in an independent office and a higher rate for the same service if the site was hospital-owned.
Which gave hospitals a strong incentive to buy physician practices, put up a new sign, and bill at the higher hospital rate.
Site-neutral reform tries to flatten that. So the logic here is that large systems want to consolidate regional market share before those loopholes fully close, because owning the region gives them more leverage with insurers.
Then we get to the next pressure wave, GLP-1 drugs. The new Medicare GLP-1 Bridge program started July 1st, 2026, and runs through the end of 2027.
KFF says about 3.8 million Medicare beneficiaries meet the strict criteria.
And the obvious question is, if these drugs treat clinical obesity, prevent future heart attacks, and reduce the need for bariatric surgery, why aren't insurers eager to cover them?
Because the clinical logic and the actuarial logic run on different clocks. The medical savings from preventing a heart attack may not show up for 5, 7, or 10 years.
And many people won't still be on the same plan by then.
Exactly. The current insurer pays the pharmacy bill. A future insurer may get the benefit if that patient changes jobs or plans.
And once Medicare covers them, commercial employees start asking for the same thing.
Which puts employers in a tight spot. Premiums are up, networks are tighter, and workers want expensive new therapies.
So some employers are trying to route around the traditional middlemen. The script points to a House committee hearing featuring Know Me Health and a model called direct contracting.
That's when the employer negotiates bundled payments directly with a hospital or provider for shoppable services like an MRI, knee surgery, or a joint replacement.
A farm to table version of healthcare purchasing.
Pretty much. Instead of buying through a giant opaque distributor, the employer goes straight to the source and negotiates a flat price.
That swaps vague network discounts for defined rates and performance expectations.
And it gives employers what they've wanted for years: more control over provider choice, more transparency before the procedure, and access to their own claims data.
So when you step back, the pattern is pretty clear. Enrollment down by millions, premiums rising, Aetna's whiplash, hospitals dropping Medicare Advantage contracts, private equity structures, copay accumulators, employers bypassing carriers.
The winning strategy is no longer just a glossy, broad network. It's active channel management.
Meaning somebody is deciding where care happens, who provides it, and who captures the money along the way.
Your coverage is not a passive all-access pass anymore. It's conditional.
And here's the uncomfortable part. If insurers, hospital systems, private equity firms, and employers are all building selective barriers to protect themselves, the patient may be the only one left without one.
You're the one absorbing the friction.
So the practical takeaway in this script is to think differently about your plan. Maybe stop treating it like comprehensive all-access coverage.
And think of it more as catastrophic financial protection, a backstop against bankruptcy if something big happens.
Then for routine care and sometimes specialty care, you may need to act more like an active consumer, the way large employers are learning to do.
It's a different mindset. You can't just wander into the maze and hope the map is honest.
You have to learn the blueprint.
So next time you look at your benefits package, ask yourself, am I making a choice here, or am I just absorbing the friction?
Keep asking hard questions.
And stay curious.